Good morning to all of our assisted living and personal care providers. This is Dale Crow from the Bureau of Human Service Licensing. Our webinar today is on infection prevention and control in personal care and assisted living. I'll go over a few of the typical kind of housekeeping issues that we always do in the very beginning. This webinar is going to be for 1 hour, roughly, and with about a half an hour of questions. When you have a question, use the, is it a question pane in the control panel? On your control panel to type in a question and send it to us. We do not see you, so no hand raising. We will try to answer as many questions during the webinar as we can. Any questions that we don't get to, we will answer them by email or voicemail after the webinar. Try to keep the questions simply to the topic of the day. And again, I always remind that there is no certificate for this webinar. When you log in, you are logged in electronically. We have an electronic log. So basically what you're going to do is you're going to log your training in your training log as you do any others. And if we would come out to do an inspection, we could look at that. Michelle Strasser is here also from BHSL. And our guest speaker today is Dr. Jane Gould, who is a public health consultant from the Bureau of Epidemiology in the Pennsylvania Department of Health. She will carry most of the webinar. So I guess we'll begin with Dr. Gould.
Thank you. Good morning, everyone, and welcome to Infection Prevention and Control in Personal Care Home webinar. As Dale said, my name is Jane Gould. I'm a public health physician consultant for the Healthcare Associated Infection Prevention Program in the Bureau of Epidemiology at the Pennsylvania Department of Public Health. Before we begin, I must disclose that my husband works for GlaxoSmithKline Pharmaceutical Company, but I will not be speaking about any GSK products today. The following abbreviations will be used during this presentation, and I will define them as we go along. The objectives of this talk include to review the chain of transmission, define an outbreak, define infection prevention and control, and the practices that we use in infection prevention and control, such as hand hygiene, personal protective equipment, respiratory etiquette, environment of care, bloodborne pathogens, especially having to do with injection safety and point-of-care testing, and then direct care provider immunizations. And then we're going to spend the last part of the talk reviewing some special pathogens. Now, a direct care worker is someone who has direct contact with residents in the facility. As you know, a personal care home or assisted living facility is a residence that provides shelter, meals, supervision, and assistance with personal care tasks to people who are unable to care for themselves but do not need nursing home or inpatient medical care. The patient population is often vulnerable to infectious diseases because of aging, poor health, mental and physical disabilities. And the setting and practices performed in personal care homes and assisted living facilities also can promote the transmission of infectious agents. The setting is typically in close proximity. Often residents may have issues with maintaining proper hygiene. There is food and drink consumption in the facility and frequently touched surfaces and high-risk circumstances such as doing in-house blood testing, having residents return from the hospital, or developing illness while in the home. According to Pennsylvania State Code, PA 2600.65, direct care staff persons shall have at least 12 hours of annual training related to their job duties, including infection control and general principles of cleanliness and hygiene, and areas associated with immobility, such as prevention of decubitus ulcers, incontinence, malnutrition, and dehydration. In point 6.6, direct care staff training plan must be developed annually, aimed at improving the knowledge and skills of the home's direct care staff persons in carrying out their job responsibilities, and must include name, position, duties of each staff person, the required training courses for each staff person, the dates, times, locations of the scheduled trainings for the upcoming year, and documentation of compliance must be kept. So how are infectious agents transmitted? There are 6 elements in the chain of transmission illustrated in this slide. The first, so we're going to start up at the top at 12 o'clock where there's organism. The organism can be bacteria, fungi, viruses, parasites, or prions. The reservoir is where the organism lives and reproduces in nature. This could be in a human, animals, even insects, water. The portal of exit is how the organism leaves the reservoir, and that can be in blood or secretions or excretions like vomitus, diarrhea, respiratory secretions. Transmission is the mechanism by which the organism spreads or travels. So this can be contact, and the contact can be either direct or indirect. Indirect contact means that you come in contact with a contaminated surface. Now your hands are contaminated. Versus direct contact is you have direct contact with a person who has the infectious organism. You can also have respiratory droplet spread and airborne spread. The portal of entry is now how that organism gets into a vulnerable host, a naive host. And this is often through a mucous membrane, such as one would have like lining the respiratory tract or the gastrointestinal tract. And then you need a vulnerable host. And the patients, such as elderly, those with immunosuppression, those who are diabetic, or those who are suffering from burn wound infection, burn wounds, are considered very vulnerable hosts. Breaking any of the 6 links in the chain will prevent transmission. We will work through this infographic that is from the Association for Professionals in Infection Control and Epidemiology. You can download this poster and hang it in your facility to remind people. So we're going to highlight how each link can be broken. Number 1, you can break the chain at the infectious agent by rapid diagnosis and treatment of an infection. You can break the chain at the reservoir level by cleaning and disinfecting and sterilization and infection prevention practices and policies that we're going to talk about. You can also break the chain by having good pest control. You can break the chain at the portal of exit also by maintaining good infection prevention practices such as hand hygiene, use of personal protective equipment, control of aerosols and splatter, respiratory etiquette, and waste disposal. You can break the chain at the mode of transmission by the same infection prevention practices, good hand hygiene, good use of personal protective equipment. We're going to go over all of these later. Food safety, cleaning, disinfection and sterilization, and isolation. You can break the chain at the portal of entry also by maintaining good hand hygiene, personal protective equipment use, personal hygiene, first aid, and removal of catheters and tubes when able. And you can break the chain at the susceptible host by immunizing the host or treating underlying diseases that make them vulnerable to infections, by providing health insurance so patients can get good medical care, and by providing patient education. So, the list of reportable infectious diseases in Pennsylvania can be accessed at this website listed here. Okay. Most diseases are reportable within 5 working days, unless otherwise noted. The following must be reported within 24 hours. And these are all listed here, and they're very unusual infections for personal care homes or assisted living facilities to see, but they're listed there for your reference. So what is an outbreak? An outbreak is an occurrence of cases of a disease in excess of what would normally be expected in a defined community or geographical area or for a typical season. You may see an outbreak occurring in a restricted geographical area, or it could extend over several countries. It could be global. A single case can sometimes be an outbreak, especially if it's an agent that's not previously recognized in that community or area. For instance, such as influenza in a group setting facility, such as a personal care home, or a multi-drug resistant organism. So it's important to remember that sometimes just a single case can define an outbreak. This table describes several hepatitis B outbreaks occurring in personal care homes or assisted living facilities that were reported to the Centers for Disease Control from 2011 to 2016. And you can see the first two here occurred in Pennsylvania. Here's one in 2016 and one in 2014. And all of these hepatitis B transmissions were because of multiple infection prevention breaches having to do with blood glucose monitoring and personal hygiene. The Centers for Disease Control and Prevention summary of data from 2008 to 2016 revealed 24 outbreaks, including hepatitis B virus and or hepatitis C virus, 179 outbreak-associated cases, and greater than 10,000 persons notified for screening. 18 outbreaks occurred in long-term care facilities or other group facilities, such as personal care homes or assisted living homes. With at least 133 outbreak-associated cases of hepatitis B and approximately 1,600 at-risk persons notified for screening. 83%, or 15 out of 18 of the outbreaks, were associated with infection control breaks during assisted monitoring of blood glucose. Additionally, in 2012, the Colorado Health Department reported 6 cases of severe respiratory illness secondary to Streptococcus pneumoniae serotype 3 among 12 residents of an assisted living facility specializing in the care of elderly persons with dementia or memory loss. 5 residents were hospitalized and 2 developed bloodstream infection. 3 residents unfortunately died. The first earliest onset case was a staff member who continued to work while sick. This staff member had close contact with all of the residents and transmitted the infection to the residents. This is called presenteeism, when a healthcare worker or direct care provider comes to work while sick. All residents and staff members had previously been vaccinated with the 23-valent pneumococcal polysaccharide vaccine, which should have protected against serotype 3. But in this instance, probably because patients were elderly, their antibody was not protective and they were vulnerable to this infection. The infection control deficiencies that were identified by that public health department revealed that employees were not aware of their sick leave policy and its role in infection control. The facility did not have written infection control policies for maintaining personal protective equipment, such as gowns and face masks, and staff members were not educated about the use of personal protective equipment. So there are many instances where outbreaks of infectious diseases have occurred in the personal care home and assisted living environment. If you have are having a cluster of infections with the same organism, or one infection from influenza or a multi-drug resistant organism, who should you call to notify? You want to first start with your local health department or district office if your facility is located in a non-county municipal health department county. That local health department or district office will then contact the State Department of Health as needed, and the Healthcare Associated Infection Antimicrobial Stewardship Team will assist or can assist with stopping the spread of infection in your facility. Okay, so now let's progress and say what exactly is infection control, infection prevention and control? Well, the World Health Organization definition is that infection prevention and control is a scientific approach and practical solution designed to prevent harm caused by infection to patients and healthcare workers. Infection prevention and control is required to prevent the transmission of communicable diseases in all healthcare settings, and it includes policy formation and implementation, education and training, surveillance, and monitoring and auditing. Infection prevention is everybody's business, and practicing infection prevention is your professional responsibility. International Infection Prevention Week is the third week of every October, every year. This is a great time to remind your staff and residents about infection prevention practices and to highlight the great work that you do. And remember, it is your professional responsibility. So performing hand hygiene is the most important infection prevention practice a direct care provider can perform to decrease the spread of infectious agents. You have options with hand hygiene. One, alcohol-based hand rub, that we will abbreviate ABHR, or soap and water. The Center for Disease Control and the World Health Organization recommend that alcohol-based hand rub should be the primary mode of hand hygiene. This slide shows the efficacy of hand hygiene preparations. To the left is good efficacy that you would obtain with plain soap and water. Better would be antimicrobial soap, but the best is the alcohol-based hand rub. A study performed by Trick et al. Looking at hand contamination revealed was significantly less likely after alcohol-based hand rub with an odds ratio of 0.03. Additionally, this study showed that there was a 10-fold higher median skin organism count in direct care providers who were wearing rings, and a stepwise increased risk of contamination as the number of rings worn increased. So the odds ratio for one ring worn was 2.6, and the odds ratio for greater than one ring worn was 4.6, so almost double. So the more rings you wear, the more likely your hands are contaminated with organisms. So the antimicrobial action of alcohol-based hand rub is that it denatures proteins in the organism. It breaks hydrogen bonds. This kills the microbe quickly and in a different way than antibiotics. Alcohol-based hand sanitizers containing at least 60 to 95% of alcohol are most effective at denaturing proteins. And actually, if you get above 95% alcohol, what happens is that you get protein clumping on the surface of a bacteria, and then the alcohol is not able to enter the cell to do its killing work. There's no chance for microbes to adapt or develop resistance to alcohol, as there is with antibiotics. So some of the advantages of alcohol-based hand rub, it's more effective against a broad spectrum of pathogens. And what we mean by that is a wide range of pathogens or germs. It also affords increased compliance compared with soap and water. It requires less time, it's less irritating and drying to your skin, and it facilitates hand hygiene at the bedside, because there's no need for sinks. There are exceptions, however, to the use of alcohol-based hand rub. In other words, when would you use soap and water? Okay, so the exceptions to alcohol-based hand rub is when your hands are visibly soiled, you should use soap and water. After caring for patients with known or suspected Clostridium difficile or norovirus, which we're going to talk about later, this would require you to use soap and water. If there was exposure to another spore-producing organism, such as Bacillus anthracis, this would be very rare in a personal care home, but this would also necessitate soap and water use. Before eating, you should use soap and water, and after using a restroom, you should use soap and water. For soap and water use, you should wash your hands for at least 15 seconds, not specifically 15 seconds, and you should use friction. The time it takes is less important than making sure you clean all the areas of your hands. And ideally, you should take your rings off when you do hand hygiene. This diagram depicts the World Health Organization's 5 moments of hand hygiene. Although there's a hospitalized patient here hooked to an IV pole, the principles are the same for a personal care home or assisted living physician. Number 1, you want to perform hand hygiene before touching the patient. Number 2, perform it before any clean or aseptic procedure, such as giving a person a influenza vaccine. Number 3, you want to perform hand hygiene after body fluid exposure, such as removing urine from a catheter bag. Number 4, you want to perform hand hygiene after touching the patient and after touching the patient's surroundings. This is a Pennsylvania Department of Health letter that was issued in August of 2017 explaining why alcohol-based hand rub is the preferred hand hygiene method in most instances. It was written specifically for long-term care facilities, but it is applicable for other group settings. You can download this from the Pennsylvania Department of Health website. So why don't people perform hand hygiene? Some of the barriers to effective hand hygiene include hand washing agents cause irritation and dryness, so then the person doesn't want to perform the hand hygiene. Sinks or alcohol-based hand rubs are inconveniently located, or there's a lack of sinks, lack of soap and paper towels, too busy or insufficient time to perform hand hygiene, understaffing or overcrowding, patient or resident needs take priority, so the healthcare worker feels they don't have time to do hand hygiene, and there's the perceived low risk of acquiring infection from the patient or the resident, or a lack of system for replenishing hand hygiene supplies. So who is responsible for restocking hand hygiene supplies at your facility? Do you know who to contact if you should need more supplies? This is something that you should figure out. Selection factors for hand hygiene agents are as follows. The efficacy of an antiseptic agent. So we talked about how alcohol is better than water and soap. Acceptance of the product by healthcare personnel and direct care providers. So it's very important to get staff input on hand hygiene agents so that they will use the product. The characteristics of the product, in other words, you can get alcohol-based hand sanitizer in a gel or in a foam, and some healthcare providers prefer the foam. You can also get it with emollients. Other selection factors to consider would be if there's an increased rate of skin irritation and dryness complaints from your healthcare workers. Also, accessibility of the product, what you're able to order for your facility, and the dispensing system. Now we're going to move on to another infection control practice, which is the use of personal protective be based on the type of patient interaction and the potential exposure to blood or bodily fluids or infectious agents. But PPE must be used properly for it to work. So you don't ever want to reuse gloves. Do not disinfect gloves in place of changing them. Don't substitute hand hygiene for glove use. Don't use gloves if they're damaged or soiled. Don't wear a mask or a respirator, put that on, any goggles or a face shield, followed by gloves last. To take off PPE, you want to start with the gloves and take them off in such a way as to not contaminate your hands, usually using what we call the glove-to-glove technique, where you grasp the outside edge nearest the wrist and peel away, rolling the glove inside out. Then you want to reach under the second glove and peel away that glove and discard them in the trash. Next, you want to remove the gown or the goggles. You can do either one, but you want to remember that the front of the gown and the front of the goggles or face shield are contaminated. So you don't want to touch the front of those things. You want to touch the back and pull them away from your body. Then it's recommended to perform hand hygiene before moving on to the next step. So if you choose to do the gown first, then perform hand hygiene and remove the goggle or face shield. The last thing to come off would be the mask or respirator. And one of the tricks for doing this is to bend over at the waist and pull the mask off, let it sort of use gravity to pull it off of your head, to get it away from your face and discard. And then, of course, whenever you remove PPE, you want to perform hand hygiene immediately afterwards. Okay, so when to change gloves? You want to change gloves if your gloves are damaged, or if you've moved from a contaminated body site, now you have to go back to a clean body site. Now you want to change gloves. Usually when you do your healthcare work, you want to move from clean to dirty, so as not to contaminate your gloves. So if it turns out that you are now working in a dirty area or a contaminated body site, and now you need to go back to a clean body site, you must change your gloves. You should change your gloves also if they look dirty or have blood or bodily fluids on them after completing a task. And remember, after removing gloves, always perform hand hygiene. Another important infection control practice is respiratory etiquette. This applies to any person in your facility, including staff, volunteers, residents, and visitors. So what do we mean by respiratory etiquette? Well, we mean several things. So one is the facility should provide ample supplies of tissues and have no touch receptacles for disposal. It should provide resources for performing hand hygiene in or near common areas. It should offer masks to coughing residents and other symptomatic persons. And it should educate staff on the importance of infection prevention measures to contain respiratory secretions to prevent spread. The staff and residents should be educated to cough or sneeze into their upper arm or elbow and not into their hands, because this will contaminate their hands. A facility may also choose to restrict visitation to persons without signs or symptoms of illness, or some facilities also choose to restrict visitation during respiratory viral season and only allow a household contact, such as a relative, a direct relative. Facilities should post signage to remind everyone to cover their mouths and nose when coughing and sneezing, to use and dispose of tissues, and to perform hand hygiene after hands have been in contact with respiratory secretions. And this poster on the right of the screen is from the CDC, and you can download this and post it in common areas in your facility. This table are examples of outbreaks that occurred in assisted living facilities from 2010 to 2013. This is CDC data, or Centers for Disease Control data, and it also includes outbreaks that occurred in skilled nursing facilities and group homes and rehab facilities. So you can see here, this has got the state listed in the first column, followed by the number of outbreaks, and then the example pathogens. And you can see there are many respiratory viral pathogens here causing outbreaks. And you can see many times influenza is listed, and we're going to talk about influenza specifically later on. Additionally, these are some example pathogens causing gastrointestinal disease. And you can see there were greater than 1,000, if you total these all up, GI pathogen outbreaks, many involving norovirus in these settings. Now, for perspective, in Pennsylvania in 2018, there were 127 outbreaks secondary to norovirus with greater than 3,000 cases. We're going to also talk about norovirus later on in the talk. Okay, another infection control practice has to do with preventing exposure to bloodborne pathogens. So this is from the OSHA Bloodborne Pathogens Fact Sheet. So what are bloodborne pathogens? This includes, but is not limited to, hepatitis B virus, hepatitis C virus, and human immunodeficiency virus, or HIV. This standard requires employers to establish an exposure control plan that should be updated at least annually, implement the use of universal precautions, identify and use engineering controls, identify and use work practice controls, provide personal protective equipment, and provide hepatitis B vaccination to direct care staff. The facility should also provide a post-exposure evaluation and follow-up program in the event that a direct care provider gets stuck with a needle or has a mucous membrane exposure to blood or bodily fluids. The facility should use labels and signs to communicate hazards of bloodborne pathogens and perform information training to its workers. Should also maintain worker medical and training records. So point of care testing is equal to a risk of bloodborne pathogen transmission. It is recommended by the CDC to not share glucometers. The Advisory Committee on Infection Immunization Practices recommendation is to provide hepatitis B vaccination to diabetic patients, both type 1 and type 2, that are aged 19 to 59 years old. Those who are greater than or equal to 60 years old may be vaccinated at the discretion of the treating clinician after assessing their risk and likelihood of adequate immune response to vaccination. It is a CDC recommendation that hepatitis B vaccination and antibody titers be done to document appropriate vaccine response for all direct care providers who are exposed to bloodborne pathogens. These are some CDC recommendations for safe injection practices. You should prepare the medication, such as insulin, in a centralized medication area. This should be a clean, dry area without distractions. Hand hygiene and PPE stock should be readily available in this area. The area should be away from food and drink and away from sink splatter. Multi-dose insulin vials should be assigned to individual patients and labeled appropriately. Never reuse needles, syringes, or lancets. Restrict the use of finger stick capillary blood sampling devices to individual patients or residents. You want to dispose of used finger stick devices and lancets at the point of use in approved sharps containers. Avoid sharing glucometers among residents. Disinfect the glucometer after use and when contaminated with blood or bodily fluids. Store in an enclosed case when not in use. This protects the glucometer from environmental contamination. You should put the patient's name label on the enclosed case. In order to prevent cross-contamination, direct care providers should avoid carrying supplies from resident to resident. You should store individual resident supplies, the finger stick device, the glucometer, within the patient room when possible, and should be in an enclosed case with the patient's name. You want to keep trays or carts used to deliver medications or supplies to individual residents outside of the resident's room. Do not carry supplies and medications in your pocket. Wear gloves during finger stick, blood glucose monitoring, administration of insulin, and other procedures involving potential exposure to blood or bodily fluids, and change your gloves between resident contact and after every procedure that involves potential exposure to blood or bodily fluids. You want to discard your gloves in appropriate trash receptacles and perform hand hygiene immediately after removal of gloves and before touching other medical supplies intended for use on other residents. Schedules for finger stick blood sampling of individual residents should be reviewed regularly to reduce the number of percutaneous procedures to the minimum necessary for appropriate medical management. You want to ensure adequate staffing levels. You should consider the diagnosis of acute viral hepatitis infection in a resident with a compatible illness, such as the signs and symptoms could include fever, nausea, vomiting, abdominal pain, jaundice, fatigue, and abnormal liver test, which typifies hepatic dysfunction. You want to investigate and report any suspected case of newly acquired bloodborne infection and report any associated infection control breaches. You want to provide staff with infection control training that includes practical demonstration of aseptic techniques and instruction regarding reporting exposures and infection control breaches. You want to conduct annual retraining. Assessing compliance with infection control recommendations such as hand hygiene and glove changes by routine observation of staff should be done, and tracking use of supplies should also be done. Okay, attention to the environment of care is an extremely important infection control practice. The environment can become contaminated with infectious materials. Care staff, residents, and visitors can contaminate their hands by touching the environment. And this contributes to the transmission of illness because now the contaminated hands, if they do not perform good hand hygiene, will then pass the contamination, the infectious agent, to a resident. Environmental cleaning is important to reduce the likelihood of disease transmission and should focus on high-touch items. So what do we mean by high-touch items? Things such as doorknobs, bed rails, TV remotes, tabletops, computer keyboards. These are things that are touched frequently. There are two stages to environmental cleaning: cleaning, followed by disinfection. Cleaning refers to removal of visible soil using detergent and water and friction or elbow grease. Disinfection can be achieved with a low-level disinfectant. You want to use an Environmental Protection Agency or EPA registered product and follow the manufacturer's recommendations having to do with the amount of product used, the dilution required, and the contact time. The contact time is the amount of time the product must remain wet on the surface in order to kill. Additionally, you want to make note of safe use. So what kind of personal protective equipment should your environmental care staff use, and disposal of the product. Lastly, the practice of vaccination of direct care providers is vital to preventing disease transmission. The Centers for Disease Control recommends that direct care providers receive the measles, mumps, rubella vaccine or have immunity to those viruses, that they receive hepatitis B vaccine. So an employer is required to offer immunization. This is an OSHA regulation. If the employee refuses to get hepatitis B vaccine, a declination letter must be placed in the employee file. Influenza. This is a Healthy People 2020 goal to have direct care providers, to have 90% of direct care providers vaccinated against influenza, and varicella vaccination or varicella immunity should be documented. If staff are vaccinated, they cannot spread infections to residents, their colleagues, and their own family members. Now we're going to move on and talk about some special mention pathogens. For GI transmission, we're going to discuss norovirus and Clostridioides difficile, which is a new term for Clostridium difficile, which we abbreviate C. diff. For respiratory transmission, we're going to talk about the cold viruses as well as influenza. And for contact transmission, I'm going to mention a little bit about scabies. So norovirus, what is norovirus? It's a non-enveloped RNA virus. It's the leading cause of gastroenteritis in the United States. It causes vomiting and diarrhea that usually lasts 1 to 2 days, but can be longer in immunocompromised or elderly persons. It can also cause fever, malaise, anorexia, and headache. Typically, there's person-to-person transmission, what we call fecal-oral. So exposure to GI excretions, such as emesis or diarrhea, and then the hands of the person get contaminated, and then they touch their mouth, and then that's how they get the virus in. Or it can be acquired through contaminated food or contaminated water or contaminated surfaces, so indirect contact. Norovirus can be shed in feces for greater than 2 weeks after the person feels better. And this period of shedding can be even longer in immunocompromised and elderly persons. Outbreaks with high attack rates, which means a lot of people get sick, are seen in semi-closed populations, such as in a personal care home or assisted living facility. It's important to know that you must use soap and water for hand hygiene when you have norovirus in your facility, because the alcohol-based hand rub does not kill the non-enveloped virus. You want to use chlorine bleach or an EPA-registered disinfectant that's effective against norovirus. It should say that on the label. It should have a label claim for that to clean the environment. For Clostridium difficile, this is a spore-forming gram-positive anaerobic bacillus, which accounts for about a quarter of all episodes of antibiotic-associated diarrhea. Why is this important? This is important because alcohol-based hand rub does not kill Clostridium difficile spores or any spores. Like we mentioned before, Bacillus anthracis is another spore-forming organism. That would not be killed by alcohol. So this requires the use of soap and water. And I mentioned C. diff because in 2018, Pennsylvania saw over 7,000 new cases of community-onset C. diff and over 4,000 cases of hospital-onset C. diff. So you are probably going to see residents who return from the hospital after having C. difficile infection. Preventing contamination of the hands using gloves remains the cornerstone for preventing C. diff transmission. And then performing soap and water hand hygiene after removing those gloves. If your institution experiences an outbreak, consider using only soap and water for hand hygiene when caring for residents with C. diff infection. So for C. diff environmental cleaning, you should use an EPA-registered disinfectant with a sporicidal claim, which means it kills spores, for environmental surface disinfection after cleaning in accordance with label instructions. The list of these agents is on the K list on the EPA website. You can also use generic sources of bleach. The bleach dilution that one should use is a 1-to-10 ratio, so 1 cup of bleach to 9 cups of water. Surfaces should remain wet for 10 minutes and then allowed to air dry to kill the C. diff spores. So bleach disinfectants may be most effective in preventing C. diff transmission in facilities that have high rates of C. diff infection. So if your facility does not have a lot of C. diff infection, then using bleach to prevent C. diff transmission is not necessary. And you can use one of the other disinfectants from the K list. Okay, common cold viruses. So direct care workers and visitors can expose residents to common respiratory viruses. Debilitated residents are much less able to cope with common viral illnesses, such as patients that have pre-existing respiratory disease, such as chronic obstructive pulmonary disease or emphysema, those with immune system dysfunction. And seemingly mild illness may take much longer to resolve in persons with underlying respiratory disease or immune system dysfunction. Most of the respiratory viruses are droplet transmission, so it can spread easily in close quarters, dense populations, and highly touched surfaces. Again, indirect contact. Remember to practice good cough-cold etiquette and to practice meticulous hand hygiene. Let's move on to influenza. So, U.S. data, approximately 226,000 hospitalizations occur each year secondary to influenza, and on average 23,000 deaths occur per year. Most deaths occur in persons greater than 65 years of age. The World Health Organization data is 3 to 5 million cases of severe influenza illness each year, with 250,000 to 500,000 deaths per year. The symptoms of influenza include fever, headache, cough, myalgias, and one can also see secondary bacterial pneumonias. A person is infectious 24 hours before symptoms occur. This virus spreads person to person, primarily by respiratory droplet or contact with contaminated surfaces. To give you some perspective for our state, in Pennsylvania, in the 2017 to 2018 influenza season, saw over 122,000 cases. 644 were outbreaks, with 601 outbreaks from long-term care facilities or other congregate living settings. In Pennsylvania in 2018 to 2019 so far, we've had 15,365 cases of influenza, with 63 outbreaks, and 50 of those were occurring in long-term care facilities or other group settings. So a significant burden of infection for the state and the country and the world. But this can be prevented by annual vaccination of both residents and direct care workers. This is the single most effective means of preventing influenza. It reduces staff presenteeism, or coming to work while sick. It reduces staff absenteeism, and it reduces transmission of influenza. You want to remember during influenza season to practice excellent cough cold etiquette, excellent personal protective equipment usage, meticulous hand hygiene, and meticulous environmental cleaning, because the environment can become contaminated with these viruses. Lastly, I want to mention about scabies. So scabies is a parasitic infestation caused by Sarcoptes scabii mite. It causes hypersensitivity reaction with raised itchy rash, and sometimes one can see burrows. You can see this linear burrow right here of the mite under the skin. Because this is highly itchy, persons with scabies can develop secondary infections from scratching and inoculating skin flora such as staph or strep bacteria into the skin. This is transmitted usually by direct contact, skin to skin, and there's a possible role for fomites such as shared clothing or bedding, so indirect contact, possible roles for that. The recommendation is to treat all cases of scabies and their contacts within the same 24-hour period with a topical scabicide. And then you might need to retreat as well. So treatment is usually a 5% permethrin cream applied head to toe, avoiding mucous membranes, that's left on for 8 to 14 hours, and then repeated in 1 week. This also may require a third application. It's recommended to no longer use Lindane lotion because of safety concerns. So contacts who are direct care providers can return to work after they've been fully treated. So what are some infection control practices with scabies? So you want to maintain contact isolation for any affected resident until treatment has been completed. Staff should wear gowns and gloves for contact, and they should wash hands after glove removal. Symptomatic staff should not work until treatment is completed. For the environment of care, you want to discard all resident creams that were used prior to scabies treatment because those might have the mite. You want to decontaminate bedding, clothes, and towels. And you can do this by washing all those in hot water and using the hot dryer setting. If the item cannot be washed, you can use dry cleaning, or you can seal the item in a plastic bag for at least 7 days, and this will kill the mite. Routine disinfection of hard surfaces is adequate. You want to vacuum mattresses, upholstered furniture, and carpeting because the mite can hide out in all those places. So again, an outbreak of scabies is defined as one or more lab-confirmed cases, meaning it's confirmed by skin scraping, which a clinician would do, or at least 2 clinically suspected cases in residents or the direct care providers, volunteers, or visitors from the facility. You should notify your local health department if you have scabies in your facility. The local health department can help you get rid of scabies. An outbreak of scabies is considered over when 2 incubation periods have passed without a new case, so approximately 12 weeks has passed. So in conclusion, infectious outbreaks are common in group care settings. Good infection control processes can prevent the transmission of infectious agents. Practicing good infection control is your professional responsibility. And to remember that hand hygiene is the single most important process to preventing the spread of infections. So become a hand hygiene champion. Obtain an annual influenza vaccination and encourage others to do so. 2, thank you for your attention and for all you do to keep your residents healthy.
Okay, well, that was great. We held that to about an hour. Perfect timing. Now we have a few questions that we're going to cover. And I'll take care of this first question. The question has to do with an additional person who's watching the webinar with another person. Can they give them credits? And yes, anybody who attends the training or watches the training can receive credits. They don't have to be registered separately or logged in to receive credits. So you would just keep track of that on your training log. And I'll just start reading these.
Sure.
The first one is, how many infected people defines a cluster?
Usually more than one.
Okay. And someone is asking if we could provide a website where they can find the reportable diseases.
Oh yeah, the Pennsylvania Department of Health website has the reportable diseases.
Was that website up on the screen at all where we could go back to it, or?
Let's see. It's chapter 27 of the Pennsylvania Code. Right there.
Okay.
Right here.
Was the reportable diseases?
See, chapter 27.
All right, great.
All right.
And this is something I've heard before as well. Regarding alcohol sanitizing solutions, they've heard that you're only supposed to use it so many times, such as 3 times before washing your hands.
No. So that's definitely a misconception, and that is addressed in this Pennsylvania Department of Health alcohol-based hand rub recommendation letter, which is actually 2 pages, but I couldn't fit both pages on the slide. There are some people who complain that after they use the product for a few times, it makes their hands feel sticky, in which case, if they don't like that sticky feeling, then they can do, soap and water hand hygiene after that. But really, the preferred method for hand hygiene is alcohol-based hand rub. Does that answer the question?
Yes. Was this ever a recommendation about alternating, or I think in the past was washing hands more recommended than using the alcohol sanitizer?
Well, before we had alcohol-based hand rub or foam.
Okay.
Yeah. The foams, it's been my experience that the alcohol-based hand rub that comes in a foam has less stickiness to it, but that's, going to be an individual thing, and that's why I mentioned that the staff should be involved with choosing what product a facility uses, because if it's something that they don't like, because they don't like the way it feels on the hand or it's drying, whatnot, they're not going to use it. And the idea is you want them to be able to use the product. You want them to be able to do proper hand hygiene.
Yeah, and I know there are a lot better ones out there nowadays with more moisturizer, where they feel more soothing, where you're not going to dry out your hands as fast.
Definitely.
Okay. And the next question is, if a staff member has a sinus infection, should they wear a mask? They may have a slight cough or drainage.
Yeah, so I'm assuming in that question that the staff member is being treated for the sinus infection with an antibiotic, but it's not specified in the question. But, you know, oftentimes with sinusitis, we don't know the pathogen that's causing the sinus infection. The physician who is treating that staff member will probably pick a fairly broad spectrum antibiotic to treat empirically. And after about 48 hours of antibiotic, the person should start to be feeling better. So symptoms should be getting better. However, if they can't control their secretions and they're doing a lot of coughing, they really should stay home from work. Because what if this was pneumococcus, like I showed on that slide with the Colorado Department of Public Health? Oops, no, going in the wrong direction. Yeah, pneumococcus lives on the respiratory mucous membranes that line the sinuses, upper respiratory tract, and, you know, can occasionally cause ear infections, sinus infections, and pneumonia. Did I pass it? Oh, well, you remember what I was... Here. Yeah. So what if that direct care provider has pneumococcal sinus infection? If they can't control their secretions because they're still very symptomatic, they could be spreading pneumococcus to all the residents and also their colleagues. So they really should be home until they feel better. And typically, like I was saying, after about 48 hours, should start to feel better if you're on the right antibiotic.
Okay. Got a few more questions. How are the rates of influenza infection determined? Are the cases ones verified by testing only, or are the cases with suspect symptoms included as well?
Well, I think it's a combination of symptoms and testing. Yeah.
When you indicated what treatment is no longer used to treat scabies, I think the webinar was, the sound wasn't good.
Oh.
Someone.
Uh-huh.
Please repeat the name no longer used.
Lindane. Lindane lotion is no longer used because of safety concerns. So 5% permethrin cream is the recommended treatment now. And there are many products that contain that. I don't want to list brand names, but basically that's the effective agent. Let's get back to the scabies part. Yes. So they want to make sure that they treat all the cases and all the contacts of the cases. So that might include direct care providers. All right, if they have scabies in their facility. And oftentimes you need a retreatment.
Okay, what happens if a facility fails to notify Department of Health of a scabies outbreak?
I don't know the answer to that question. I really don't know, because how would the health department know that it wasn't reported? But I think, you know, the health department, in particular, the Bureau of Epi with the Healthcare Associated Infection Prevention team can help the facility get scabies out of their facility. But if it's not reported, we're not going to know that it's, you know, occurring. So I don't know how any kind of punitive action could be taken then. So I really don't know the answer to that. They're supposed to report. So it is part of PA code. It's supposed to be reported.
Right, and you know, as a regulatory agency, you know, BHSL, if we find that's not reported to the Department of Health, that I imagine could be cited as violation on our end.
Yeah, I would think we certainly could cite them if we were aware of it.
Yeah.
again, it's the awareness. So it's, in this case, the reporting of diseases is just vitally important for everyone.
And that's listed in the RCG as one of the
appendix. So, so this would basically be a citation under other
18,
other
2600,
code
2018.
or
Right.
laws for us.
So, and I understand, I mean, it would be most beneficial to report it to hopefully have assistance in
Yeah, we can help.
Right.
This is one of those cases where what I like to tell people when they ask us to, even like just reportable incidents, if you're not sure, report it. I always say, when in doubt, report out. It can't hurt because someone else could then correct you and say, well, this wasn't really reportable. Okay, well, so be it. But at least you made a good faith effort, which could save a lot more outbreaks and lives later.
Okay, and there's another question about how do you show proof of this class? They missed the information previously. Just keep track of it on your training log, how long you were on it, and the date and everything, the topic. You can't really show proof that you were on this webinar, but we have a list of everybody who was on it and how long they were on it if we need to see that for any reason. So you wouldn't really show us proof, but if we needed to know for sure if you were on this webinar, we could check. Okay, is it recommended to have an infection control coordinator to oversee the organization's infection control program? And what would be the qualifications for someone to serve as an infection control coordinator?
That is a great question. So I don't know what the DHS regulations are for personal care homes or assisted living facilities, but I would think it would be helpful to have a direct care provider, such as a nurse of some sort, who maybe has an interest in infection control, a particular, interest and wants to be the infection control person for that facility, someone that everybody could go to with a question. The APIC that I mentioned before has great training courses for infection control and prevention, and they have you can sit for an exam to become certified and get, be certified in infection control. So that would be like the ultimate. Like, you don't have to have somebody with that degree of knowledge and certification. It could be somebody who, has a particular interest in infection control, has participated in infection control webinars and educational events, and has done some reading on the topic to be the point person for your facility.
Right, there's no regulatory requirement under Chapter 2600 to have such coordinator, but it sounds like a great idea, and it would probably help with meeting OSHA requirements as well.
Sure.
And it could be part of a quality management plan.
Yeah, quality management is 26A and B and C, and there are certain requirements, not specifically an infection control person, but reportable incidents, complaints, staff training, licensing, resident counsel, etc. That certainly could be certainly made a part of your quality management team, and certainly a best practice.
Okay, the next question refers to wearing rings. It was mentioned with increased organisms, but how about long artificial fingernails?
Oh yeah, same thing. Yeah, there have been studies in acute care hospitals of nurses, specifically in neonatal intensive care units, that had were wearing long, had long nails or artificial nails, and it was linked with a Pseudomonas outbreak in the neonates in the neonatal intensive care unit. And there have been other instances where it's been shown that we harbor microbes under our nails. So it's really best to keep the nail length short to maybe 1/4 of an inch above the fingertip, no longer, and to use ideally clear or pale colored nail polish so that you can see if there's dirt under your nails. To avoid the acrylic nails or any kind of jewelry and doodads that people put on their nails because they can harbor microbes.
Next question. I believe you said employers are required to provide Hep B vaccines to direct care staff?
Yes, that's an OSHA requirement.
Okay. It's not one of our requirements under BHSL, Chapter 2600, but it is an OSHA requirement?
If they're going to come in contact with bloodborne pathogens, they should be protected. Yes.
Are they required to offer it or ensure that they did have it?
No, offer it, because remember, they can sign a declination if they refuse, but they need to be counseled then that they are vulnerable to hepatitis B and they're doing high-risk jobs.
Okay, how do you get a copy of the slides for the presentation? It is attached to this webinar in the handout section, but if you can't access it there, please give Dale Crow send him an email and he'll send it to you. It's dkrow@pa.gov.
Yes.
Okay. What should you do if a resident refuses the flu vaccine?
Well, there's not much you can do. They can refuse, right? But sometimes I think if you just spend time with them and educate them and tell them this is something that you've done yourself and all the members of your family, sometimes I think you can get people who are hesitant to get the flu vaccine to reconsider.
You hear it all the time that people say, well, I'm afraid of getting the flu from the flu vaccine.
Yeah, that's another fallacy. You can't get influenza from the flu vaccine. The flu vaccine can make you feel kind of achy. You can definitely have pain or soreness in your arm where you get the shot. And it can make you kind of feel achy and stuff. But that's a cytokine response to the vaccine. That's not the influenza virus in your body. And it's usually pretty short-lived, not usually longer than 24 hours, versus influenza gets worse.
Yeah, and another thing I hear is, I never got the flu before, so why should I get a flu shot now? But I think the answer, obviously, is they live in a group setting now, and they're going to be more likely to get it.
Yeah, and you can get influenza anywhere. You can go food shopping, and it can be on the handle of the shopping cart, the doorknob to the store, anything. It can be on your money. So any high-touch item can become contaminated with respiratory viruses, including influenza. So you never know where you're going to get exposed to it. But if you're working in an area where there are lots of residents in a confined space, you're high risk. You're in a high-risk situation, so you should protect yourself. And by getting the vaccine for the healthcare provider, the direct care provider, they're also protecting their family because they're not going to be able to bring influenza home to their own family. And then they're also protecting the residents who can't get vaccinated or choose not to get vaccinated.
Okay, and can personal care homes use this PowerPoint to train their employees for infection control annual training? The answer, as long as it's okay.
Yeah, sure, I'm flattered.
Okay.
Thank you.
But on our end, as far as BHSL is concerned, yeah, sure, that would be a great idea. Okay, with influenza, it is recommended to wear a mask, gown, and gloves every time you go into that resident's room, even if you're not performing direct care. Speaking about the gown most, they're wondering if it's recommended to do that.
Yeah, so influenza is spread by respiratory droplets. So you have to get within 3 feet of a person to be sort of exposed directly from that person, within 3 feet of them. Now, if you remember, in 2009, when we had pandemic influenza, the CDC initially recommended airborne isolation of those patients and required special respirator. Airborne viruses can be spread 6 feet because they're smaller molecules, smaller suspended virus particles in the air, and they can travel 6 feet. So if it was an airborne illness, tuberculosis or pandemic flu, they would say anybody who's going to come within 6 feet from the patient should wear personal protective equipment. Okay. Now, these viruses also can contaminate surfaces. Okay. So a resident might not be able to control their secretions. So I could envision this scenario where a direct care provider would be getting within 3 feet of the person, and then the person sneezes or coughs all over their shirt, all over their jacket, right? Now that virus is on their clothes. Now they're going to do the rest of their work. They're going to go to other patients. They're going to have lunch with their colleagues. Meanwhile, they're touching their shirt. Now their hands are contaminated. Now they're touching their colleagues, shaking hands, high-fiving, whatever. So that's how it spreads. So I would say, wear the gown. They're pennies. They cost pennies. Wear the gown, wear the gloves, protect your own mucous membranes if the person cannot control their secretions. It's a different story if the person's not actively coughing and sneezing. You're only going to go in to put a tray on a food tray on the bedstand or something like that, and you're not going to be within 3 feet of the patient.
I think we want to remind people, though, that, in the personal care settings, that it isn't always just direct care staff. It could be housekeeping people or people that work in the kitchen and so forth, that deliver trays and things like that. If the good personal hygiene techniques that we're talking about, I think, apply to anyone, and especially the people that Dr. Gould is saying that do come in contact with the person or within several feet of the person, and any of surfaces that the person may use.
Okay, moving on. Is there a specific percentage of alcohol needed in the hand sanitizer?
60 to 95%. That was in one of the slides. Yeah.
Are dry used paper towels still harboring live germs/disease?
Yes. Viruses can last on inanimate objects for weeks. So yes, those are considered contaminated once they've been used and thrown away.
Okay, why are gloves removed before goggles and protective clothing? Wouldn't gloves help to protect staff person from touching germs on the clothing?
So once personal protective equipment is used, the front of the goggles, the front of the gown, and your gloves are contaminated. So it's recommended that the gloves come off first, then you reach behind and remove the mask or the eye protection, or you reach behind and untie the gown and pull it off. And with every step, it's a good idea to do a quick alcohol-based hand rub between the steps.
Okay. Are we able to access the written part of the webinar to educate staff? I guess the notes are in the...
Well, I could type them up and give them to you, and you could send them to all the attendees if you'd like. I'd be happy to do that.
Okay. What are the facility's responsibilities to vaccinate residents for pneumonia and varicella? We don't have any requirements under our regulations, the 2600, but
No, no regulation that I know of. But, you know, the Centers for Disease Control does recommend that the direct care providers, so the staff who have direct care to patients, they should be protected by vaccination.
Okay, and someone is asking, can you explain how to download this presentation? I believe in the control panel, there's a section called handouts. I don't have it in front of me. You can go to the handout section. I think there's a little something you can click on that says handouts, and then print it from there. But if you can't get that, just go ahead and email Dale at dkrow@pa.gov, and he can send it to you. And is this training being recorded for future watching? We do record all of our webinars, but it's up to Dr. Gould if she...
That's fine.
Okay.
Yeah.
So we should be able to put it out on our website then for future viewing.
I'm glad they see value in it. Thank you very much.
Definitely a lot of information, a lot of good information.
Yeah, it's hard to cram in all these topics in one talk. There's so much more I could have spoken about, too, you know.
Okay, well, that was the last question that I had. So I think we can conclude there.
Thank you, Dr. Gould.
Thank you.
This is very important. And just as a reminder that we try to have a webinar roughly about once a month. So this was a good one to kick off 2019.
All right, and as always, if anybody has any suggestions for future webinar topics that we're not thinking of, please let us know. You can email Dale at dkrow@pa.gov. And I just give his out because it's quicker. He's got a shorter name than I do. But go ahead and email us or give us a call, and you can let us know. If we're missing some topics that you think you would benefit from, we'd be happy to look into having training on different topics. So thank you very much for everyone joining us today. And once again, go ahead and email us if you need a copy of the presentation, or we'll be sending it out with the notes to all the attendees when we have that. All right, everyone, have a great remainder of your day. Thank you.
Thank you.